Welcome, everybody. It's a great delight to be at the American Society of Clinical Oncology, ASCO, here in Chicago in 2026. It is a great delight to be here with our colleagues. My name is Ghassan Abou-Alfa. I'm from Memorial Sloan Kettering Cancer Center, and here we are to introduce the study that we reported here at ASCO, the EMERALD-3 study. I'm joined in by many colleagues, and would love to have me sure they introduce themselves.
I'm Dr. Gentry King from the University of Washington Medical Center, also Fred Hutchinson Cancer Center. I'm a medical oncologist.
I am Mehmet Akce, GI medical oncologist from University of Alabama at Birmingham.
I'm Dr. Pierre Gholam. I'm a hepatologist at University Hospitals of Cleveland and Case Western Reserve University School of Medicine.
I'm Lingling. I'm a GI medical oncologist with Ochsner MD Anderson Cancer Center in New Orleans, Louisiana.
My name is Burgoyne. I'm a GI medical oncologist at UC San Diego.
Hello, I'm Lipika Goyal. I'm a medical oncologist at Stanford Cancer Center.
My name is Riad Salem. I'm an interventional radiologist at Northwestern University.
So nice to see you all. And it really was a great honor this morning to present on behalf of all co-authors and colleagues the EMERALD-3 study. And EMERALD-3 really is based on the idea of embolization. And Dr. Salem, you are our interventional radiologist expert. The argument that we brought into the study that when we give the embolization, we actually induce a activation of certain antigens that automatically will activate the immune checkpoints. Your thoughts? Does this make sense?
I think it makes sense. I think clearly historically we've shown that actually does happen. Mm-hmm. There is a rationale to it, so there's a scientific rationale to making those combinations. Depends what you're combining, VEGF activity or anti-VEGF activity, whatever that may be. HIF1 alpha has been shown as well. So there's a variety of things that happen after embolization. And I think the combination, we are now seeking what the right combination actually is by trial and error based on the agents that we are using now. So I think there's rationale. And this is a major advancement, certainly for me as an interventional radiologist.
Good to hear that. And I'm kind of like pleasantly surprised you bring the VEGF, but as you noticed, we kind of like put in more checkpoint inhibitors into the game. And actually, maybe Gentry, kind of like tell us about the checkpoint inhibitors. We used the Tremelimab, Durvalumab, and we added also the antiangiogenic, which is the Lenvatinib. Your own personal opinion, which one you really put more weight on? Just your view, your perspective.
Yeah, I mean, when you asked about, there's definitely preclinical evidence. There's a lot of theoretic synergy. It always, to me, is the question of the magnitude that synergy you see in these large trials, whether it's really, synergy 1 + 1 is equal to 3, or it's merely additive. But with that in context, I do think it's the IO that I pay more attention to. And in fact, when you look at the data here, it reminds me of Himalaya, that long benefit towards many years out, which you don't see in the first few years anyway. I mean, first year or first 9 months, the curves are overlapping. Himalaya PFS was negative, OS positive. So it's a very interesting evolution of what we've been trying to do over the past few years.
No, I like what you said, and I give credit, actually, as you remember, Dr. Katie Kelly, our dear colleague who really was chairing the session or co-chairing the session, really pinpoint on that point of the IO. So as such, you're right. So what we did in the study, as many of us we know, we actually, yes, of course, we're looking at chemoembolization, and we add to it, exactly as we just heard from both of you, the IO, which shows, of course, the anti-CTLA-4, which is Tremelimumab. We added also anti-PD-L1, which is Durvalumab. And also we added antiangiogenic, which is the Lenvatinib. And then, of course, we really need to kind of look into all of this together to understand what's going on. So, Dr. Gholam, so in regard to the criteria of the eligibility that we put in for that study, and you remember somebody in the audience asked me, like, well, what's intermediate stage? As a gastroenterologist, hepatologist, what's your view? Who really is intermediate stage for you?
I think BCLCB is certainly the most problematic of the BCLCB stages. It's such a heterogeneous group of patients that range from patients who have relatively confined or limited disease all the way to patients who have multilobar multinodular disease. Those all fall potentially under the category of BCLC-B. And I think because of that, it's historically been a challenging group of patients to study. Certainly, the interface of stage of disease with liver function, however you choose to call it, is critically important here. And I think we'll learn a lot about how the combination of locoregional therapy and systemic therapy impact liver function over time. You gave some glimpses of this today, but we'll learn a lot more, I think, moving forward.
No, thanks so much for that. So, in other words, we ended up doing chemoembolization. Arm A was chemoembolization, of course, plus the tremelimumab plus Durvalumab, which now is called the STRIDE regimen, and add to it Lenvatinib. Arm B was the TACE plus the STRIDE, and Arm C was TACE. And the design was, admit, it's complex, but nonetheless, we thought Arm A compared to C makes sense. We're trying to see if you add on the double checkpoint inhibitors and the anti-VEGF and compare them to chemoembolization. And at the same time, we wanted to check on Arm B versus C, which is STRIDE plus TACE compared to TACE. I'm eager. I would love to hear from either of you, just like the statistical design. We kind of put this nice kind of layout of it. Like, did it make sense in regard to PFS, primary endpoint, etc.? Yeah, please carry on.
Yeah, I think the study design definitely makes sense. Of course, my the one arm that I'm most interested in hearing about the result is actually Arm B, the STRIDE plus TACE, because I do feel that realistically, it's way much easier for patients to tolerate TACE plus STRIDE versus TACE plus STRIDE plus Lenvatinib, right? We all know the harsh part is probably the Lenvatinib, not the STRIDE part. So I'm actually quite surprised and also very pleasantly surprised to see the result that Arm B actually did very well.
Yeah, no, I totally agree. And if anything, the design was that we will look into the progression-free survival and compare A to C. And then if it really matures enough and we have statistical analyses that we're able to complete, we'll move on to analyzing the next step, which is overall survival of A versus C, then move on to progression-free survival B versus C, and then overall survival of B versus C. Riad, you and I had a long chit-chat about the PFS, and most of us are more into the oncology world. Tell us, would love to hear your perspective on PFS and primary endpoints.
I mean, it makes sense to be using PFS as primary endpoints for a lot of these diseases now. We know that overall survival now has become more and more challenging with all of these post-treatment progressions. It is a natural evolution to use something like that. And there's really clinical relevance. If you declare somebody a progressor, then you're going into a category where there are few treatments, right? You want to delay that declaration because you have few treatment options after, right? So it makes a lot of sense. And for me, when I think about PFS, I think PFS is not a pure surrogate for overall survival. We know that, but as an amalgamation built with PROs, response rate, quality of life, these are all things that are very important clinically. So it is quite possible to have a relevant PFS observation with very relevant secondary endpoints that move things clinically in advance, things for the patient, as opposed to just looking for overall survival. So I think it is. And just last thing to say about PFS, I mean, once you progress, you're maybe out of transplant criteria, maybe you have more pain, you have more dysfunction, you're out of other types of imaging things that allow you to get other types of treatment. So I think PFS is a very relevant endpoint, and put together with a relevant group of secondary endpoints like OS and PROs and response rate and preservation of liver function, like Pierre is mentioning, I think is very relevant.
Yeah. And I also think that with a PFS endpoint, for me as a medical oncologist who we actually treat our patients, selected patients with combined, say, TARE plus STRIDE regimen or different immunotherapy regimen. I think this morning, the other study that they were also doing the combination, there was a few case presentation that they were saying these are the example. That was exactly what we're looking for. There were patients who respond very well, that the complete response lasts for many years. And there were even patients who responded so well that eventually they could be downstage to potentially curative treatment, right? So I want to see on the study with longer follow-up is on the PFS curve, is there a tail? like with the combination, is there patients for many years later still remain like not at progression, and that's meaningful for those patients.
No, absolutely. I totally agree. Actually, I admit that we're a little bit struggling with the PFS business, but I think because everything kind of matched, ultimately, it was definitely very valuable. Dr. Goyal, you and I will go a long way in regard to is HCC one disease, multiple diseases, especially when it comes to etiology. And if you recall, we had a little bit of more omnipresence of 40% plus of the Hep B, and we had about, quote unquote, about like 40% of the non-viral, and a rather lower stat of the Hep C. Does this make any sense to you, how you interpret this one way or the other?
Yeah, thanks, Ghassan. There have been lots of studies now looking at, does it matter if you have viral hepatitis or not in terms of whether or not the HCC is is IO responsive.
Yeah.
And I think overall, it seems like whether you have Hep B or Hep C or MASLD or another etiology, overall, all of these different etiologies, the tumors do end up responding to IO.
Yeah.
And there isn't like a skew towards one versus the other. There was some question previously about it, but I feel now with more studies coming out that even whichever etiology you have, there's a group of patients within each of those etiologies that respond.
Yeah, well, it's good news. We all have a immune system working, so that's good. So good. So, Mehmet, as you probably noticed on the study, we kind of like did the planned analysis about 175 patients per arm. And if you recall, I mentioned also that arm A and C, we're going to continue expanding for more patients. So end up close to about 250 plus patients. This really worry you in any way, like as if this test design was not really set up, or you took it at face value that the more patients you have, the better the separation you have?
I think having more patients would inform us further about the toxicity profile and the efficacy of the regimen for sure. But the trends are so strong, and I think adding more patients would probably end up just helping further to cement the efficacy and safety of the approach. So I wouldn't be concerned about that.
I agree. And one point that we noticed is in regard to, and this, remember, Dr. Kudo, who is a great co-principal investigator of the study, he brought to us the concept of up to 7 criteria, where we calculate based on the largest lesions in the liver, we measure it, and then we calculate how many lesions in the liver, and you have the less or more than 7. In your experience, like how much do you really pay attention to this, or how much does it matter?
I mean, I think having some set of criteria to help address the heterogeneity that Pierre was addressing from before.
Yeah.
Are we thinking of these studies as upfront definitive therapy with locoregional treatments followed by an adjuvant approach with immunotherapy? Or are these folks that are just getting earlier introduction of immunotherapy because they have diffuse bilobar disease? One missing control arm here that I think would be helpful in some of these studies is what if we didn't do TACE and just had earlier intervention with STRIDE or STRIDE plus Lenvatinib in this higher risk.
You're the second person to bring this up.
So, I mean, we can only have so many arms per study, but it is a remaining question.
No, you bring a very important point, because Dr. Kudu did. In others, he made an argument that more than up to 7, maybe we should really do systemic therapy only. Anyway, for our colleagues, what you just heard from all of us here, that the EMERALD-3 study was based on an argument that adding on to the transarterial chemoembolization some potential argument that with the antigen that really are brought in because of the inducement of or induction of the chemoembolization will cause the immune enhancement of activity with the checkpoints, and as such we will oppose that by adding on the Durvalumab, and we probably will look at the antiangiogenic as being a further enhancer to that component, and of course, at the top of the chain of command, the Tremelimab in the anti-CTLA-4. As far as the etiology, as far as the demographics, I think we all agree this is exactly what we see day to day, and these are patients who are amenable for the use of the local therapy. They are not amenable for any surgical intervention or a curative intention. And at the same time, as we just heard, also they're not necessarily the patients who are right for giving the systemic therapy. The up to 7 criteria is a little bit, debate. I think Dr. Salem is not necessarily the kind of, big supporter of, and we differ in opinion on that. But more importantly, we can assure everybody that this was really the true population that we all do see day to day in clinic. In regard to the statistics, we just mentioned that we did it in a continued scaling, and we did the PFS for A versus C, then we did the OS A versus C, then we moved on to B versus C. However, there was a lot of talk about the Lenvatinib contribution here, and the question about the story of A versus B, which in other words, TACE plus Lenvatinib plus stride versus TACE stride. Before we go over the data, I would like to hear anybody in regard to the argument about this A versus B that was brought in endlessly by many of the colleagues, being either the question session or even beforehand. Any thoughts, Gentry?
I think the data was very compelling that the Lenvatinib didn't really add much, but instead added more toxicity.
Yeah.
A lot of discontinuations. It really also reflects what we experienced in clinic as well.
Yeah.
What were the other comments, Ghassan?
No, you're good. You got it. That's exactly what it is. You're absolutely right. And I think I give credit. A lot of people said, what? It looks like a story that you don't need the Lenvatinib. You hit it right on. And interestingly, just to help remind everybody of the results, the progression-free survival was for the A, being stride plus Lenvatinib plus TACE was about 13 months. And it was for the TACE itself about like 8 to 9 months. And then interestingly, the PFS, this was, by the way, already complete and definitely mature enough, and we're able to analyze it formally. But the other analyses were not yet mature. Nonetheless, we were able to, of course, interpret them. And there was the same trend in regard to the TACE plus stride, arm B, in regard to 13 months compared to about 9 months for the TACE by itself. And the question then, according to, as you just mentioned, Gentry, is like, does did Lenvatinib add anything over here? And that's really the point that was brought in. And to that matter, Mehmet, if you recall on the demographics, the population from Japan was rather a small population, so about like 7.5% of the study. But nonetheless, they really did better. If you look at the subgroup analyses, like everything is like favoring in regard to the equivalency between the two arms, but this subgroup really look better to do with Lenvatinib plus TACE plus stride. Any thoughts? And by the way, not that anybody of us know.
It could be really related to the disease biology, specific to the Japan, and their population characteristics of the tumor, underlying etiologies, and the driving factors might be slightly different, and that might be driving the differences based on the geography potentially.
Yeah. No, you're absolutely right. Actually, if anything, surprisingly, in Japan, where Hep C has been really the driver, but now in reality, MASH is kind of like becoming the lead, and there was more non-viral in Japan, and interestingly, you can connect that non-viral with the Japan population, and we can see that exactly that finding. But however, the experience of the Lenvatinib, and Lipika, you're really, highly experienced in this, but to be fair, in Japan, they are more experienced with the Lenvatinib. Tell us about your hands-on experience with the Lenvatinib first.
Yeah, well, the good news is Lenvatinib is a really effective drug in HCC.
Yeah.
But with that, the trade-off is it does have a lot of side effects. It's one of the most potent VEGFR2 inhibitors that we have among the multi-kinase inhibitors. Whenever we have randomized trials where investigators can choose Lenvatinib or sorafenib, majority of the time, people choose Lenvatinib because it has good efficacy. But you see a lot of the VEGFR2 side effects. So you see high rates of hypertension and proteinuria. We also see GI side effects. They dose it often based on weight, but we often do dose reductions with Lenvatinib because being on a long term can be hard to tolerate. We see some hand-foot syndrome, some cytopenias, but it's mainly the hypertension, proteinuria, and GI side effects, decreased appetite.
Yeah, no, I would say that it's not the most pleasant, but to be fair, I like that you brought in first. It's an effective drug. We know it's an effective drug, but definitely bring in some toxicity with it. Let's just kind of like hold off a little more on that PFS story. I think I have to remind everybody 13 versus 9 months anyway. And this trend, of course, applied for the B versus C. OS. OS was kind of like impressively, number one, pretty good, about 39 months for arm A versus about 34 for arm B. And for arm C, and for arm B, it was not even reachable. We didn't even see median. And then on the other hand, we saw, of course, the same thing, 34 months or so in regard to arm C. That is really kind of like does it really kind of like make you question that PFS story when you see this OS, or support it, or your thoughts?
Obviously, the data is still early, and we'd like to see more long-term follow-up for the OS. I mean, it's supporting that PFS may be behaving as a surrogate early endpoint for efficacy that may translate into survival, but certainly it's exciting that we're seeing that difference that we haven't seen in some other studies.
Yeah, no, fair enough. And Pierre, so let's theorize this. You have the population already, you have this separation, and to totally concur, the maturity of the data for the OS was about 45%. In other words, but the question for you, what's the chance those two arms are gonna like cross at any time?
Well, I guess only time will tell. But one of the reasons I believe this may not happen, as in there will remain some separation between the two arms, is that I think that as you start doing what I like to call planned multimodality therapy, where you commit from the get-go to basically give the patient both locoregional therapy and systemic therapy, I think you approach your PFS and your OS become more tightly linked, as opposed to when you give somebody one modality. Typically, the classic example, of course, is the REFLECT trial, where your PFS was, of course, sky high, but your OS between, this is ancient history now, between sorafenib and lenvatinib was essentially the same. And I think this remains somewhat unexplained, but I think to some extent, when you max out on modalities of therapy, you potentially are likely to have a tighter correlation between PFS and OS. That's fair just enough. my opinion.
No, fair enough. I would say that, short off, this is my view, but I would love to hear yours. Short off, you put everybody on arm A or arm B in a bus, and they just drop off a cliff, and you flip those PFS. There's no the OS. I didn't really see a sense. It's really kind of like already matured enough.
Right.
What do you think?
I feel that actually it's the first time that I see from the combination trials after all the like LIP-012 and the EMERALD-1 that we had. It's the first one that I see the over survival. It's actually, the curves are quite encouraging.
Exactly. No, I totally agree.
I think the CTLA-4 is what's important in differentiating things here. Like, this is our first study that's showing that early introduction of CTLA-4 blockade is perhaps leading to some long-term memory similar to what we've seen in Himalaya, and hopefully those curves will continue to be separated for longer-term follow-up.
No, I totally agree, and I concur with you. This is like the view on it. Any of us opposed to that? Like, they think that PFI OS might still flip around?
No, I'm not opposing.
But you have an argument. Go ahead.
No, there was if you look at the OS for the first 12 months on arm A versus C, they did flip.
Okay.
And then they separated there out. So this reminds me of Checkmate, where the toxicity, and if you look at the median duration of patients remaining on treatment, it was shorter on arm A.
Yeah.
So I think OS has a powerful statement there, and not only in terms of tolerability, but like having patients deteriorate with the treatment that you're giving. But it survived that flip, and I do think this is going to stay separated. It looks promising.
Yeah, kind of this flip, we spoke about it. But to be fair, remember the checkpoint inhibitors take time to prime them.
Correct.
Our immune cells is not like ready to do this. It's almost like intelligence. They have to go and learn the immune system to be able to counteract it. So that's really where kind of like sometimes it drags a little bit of time until it separates per se.
Actually, my one of the things I was thinking about is whether the Lenvatinib had a contribution to sort of a decline in the first few months.
That's how I feel, because I feel that the arm B versus arm C one, it's pretty like start separating early, over survival curves separated early.
Right.
I definitely feel that people can definitely tolerate this regimen better.
Yeah.
I wonder whether some of the clarity that we see now in this more contemporary trial versus something like the SPACE trial, which Riad will probably recall quite well, is the fact that there has been a much more codified and concerted effort to standardize the procedural part. If you recall, the SPACE trial involved patients all over the world. Some of them had super selective TACE in Japan, where they would get this ad nauseum, and some in Mexico would only get one TACE over the course of the study. I'm just curious whether, Riad, you think that had something to do with the...
Yeah, I mean, I think there's no doubt that over the last decade, the message has been heard loud and clear by at least my society and our field. We recognize the need for selectivity. We recognize the need to maintain liver function. This is all stuff that we've learned by working with medical oncology and hepatology over the last 15, 20 years. So we recognize that. I do think the term embolization eligible is actually interesting here, because it's always very easy for everybody to say, oh, this group is very heterogeneous. Everybody says that. Well, hold on for a second. Embolization eligible now starts to really hone in on a pretty I'd say tighter patient population, right? Those that you can embolize in one or two treatments are clearly different than somebody you can do TACE on. You can do TACE on anybody, but whether you should or not. And so I think the nice part of this study is actually it is less heterogeneous than other types of trials. So I like the EEHC, frankly, because I have a good idea of who these patients are. They're not multifocal by a lobar. There's not 30 tumors everywhere. I look at the up to 7 and below up to 7. I can basically tell who these patients are. And that's a tighter patient population, which allows us to really pick what patients are going to be good for this combination.
Yeah, no, you bring very important points. So again, for our colleagues, so what we're just talking about here is OS component. And yes, it is only at 40% maturity for arm A, 45% for arm B. But to be fair, the separation is already there and it's declaring itself. So it's probably, and of course here we're talking as academicians, but it's unlikely to flip around. But of course, we're waiting more for that form analysis because we just like the math. So that's simply what it is. Interestingly, however, I like very much the point that was brought in regard to really who's playing to all of this. And I am very impressed, and I totally agree on the CTLA-4 story. As we all know, CTLA-4 is really I always like to call CTLA-4 as like being the CEO of the immune system. And this, if anything, it really controls all what's going to happen below it. And interestingly, specifically, Durvalumab is a very robust anti-CTLA-4 because even we have our own anti-CTLA-4s called CD28. Amazing. It's 3 times more potent than CD28 that we have in our own body. A drug which is really more potent than your own natural system that you have. And exactly, I totally concur. It's like one dose only is enough to do that activity. And probably, yes, you're right, it impacted that survival per se. This, however, you bring us back to the issue of the population and specifically in regard to the kind of, what you called, this is really, I agree, this look commensurate among themselves. And I think it's a good reminder of the real world data component. And this is really what it is. So Dr. Goyal, as you remember, we tried to pin down, and not only in this kind of field, but in many fields, super select criteria for trials. And now tell us, are we changing our mindset in regard to trials, looking more real world? What are your thoughts?
Yeah, there's been a lot of effort to think about eligibility criteria to make it as inclusive as possible for patients to join, but also you want to be able to see a signal, so it has to be narrow enough that you're having healthy enough patients to check. I agree with this question about the embolization eligibility. What who's embolization eligible for Riad Salem might be a little bit different than who's embolization eligible for other IRs at different groups. So I think it will be interesting to take a look at the baseline population and see how many tumors, what size of the tumors, the location of the tumors, and just see if there are any differences by that information. Glad overall that it included, it was a global study, including many different centers, and include all etiologies and et cetera. This study, I believe, did not include Child-Pugh B7.
But they can make it B7A6 very easily. It's like magic.
Ghassan, that's because you're a hepatologist and an oncologist all in one. I did want to make one comment about the PFS OS question.
Sure.
While the curves are unlikely to flip, I agree that if they're going to flip, it seems like it's more early on rather than later on. The hazard ratio was 0.70, and the upper limit of the hazard ratio in the range was 0.95. And so I look forward to seeing the more mature data, as you were saying, it's about 45% mature, to see if that hazard ratio remains significant or if the curves come together with time to see if there's a difference. I think the big question for all of us is now or later, as Stephen Chan, expressed in the discussion today, if there continues to be an overall survival benefit and that hazard ratio continues to be significant, great, then potentially we can think about having a new standard where we all give Durva and Tremi up front, then have TACE, and then continue the Durva. If the curves come together, or if that overall survival benefit does not seem clinically meaningful, then I think this idea of having these patients in Dr. Salem's hands, get the TACEs, and then come see all of us as medical oncologists 1 year later or 2 years later. And, even though having Durvalumab once a month is less time intensive than some other regimens that are more frequent, it's still this feeling I feel for patients that they're tethered to a geography and to a location because they have to come in once a month to get infusions. And so the trend looks very encouraging, and we're always trying to make advances to improve survival in the intermediate stage setting, because for a long time we've mainly had liver-directed therapy. But I also love it when our patients can just be in the hands of our IR doctors and don't need to come see us, because that's less time toxicity for them in our clinics.
Fair enough. So we're hearing a lot here about what we call real-world data. And to give credit, the community in oncology has realized that, after all, if you're going to be super selective with your studies and you start kind of like pin down every criteria, you end up with like really patients that don't even exist, only except on trial. And as such, like the art of trying to bring this in to the real world is very important. And if we recall, all of us, and I think you remind us of the space study, the criteria in regard to who really go on the study really softened up a little bit, not because we're trying to accrue more people, but really to translate it into the real world data. We go back now, however, to the issue of the OS and PFS. And I would like to really hear, maybe it might look like a little bit more, philosophical view, but it's very important to, what's PFS? And what's OS too?
I think, now that I've heard everyone's discussion, funny thing is, like, before this presentation, I was really waiting for the OS.
Okay.
Because of the prior
experience. Because you're an oncologist.
Yes, that's one thing, right?
Yeah.
And then the other is the prior studies like LEAP, EMERALD-1.
Yeah. And
then there's no systemic control arm.
Yeah.
It's always the OS that to me would matter, because as an oncologist. But you're right. I think PFS does have a clinically meaningful impact.
Yeah.
As you might also see how it plays out here on the OS in the first few months.
Yeah.
I think, especially with the toxic regimens that we can give to patients.
Yeah.
I know that's not radiographic PFS.
Yeah.
But at the same time, when patients start to deteriorate because of radiographic progression, and there are, especially in liver cancer, there are a myriad of situations that can happen like that. I do think that it's important.
Yeah.
So PFS to me is, after this, I think it's become more meaningful to me as an oncologist.
Yeah.
Yeah.
No, I hear you. And interestingly enough, if we think about it, like PFS is easy to interpret because either bigger or smaller. It's very easy to really, and it's nice to tell it to the patient. As you remember, when I started kind of like introducing the study, I kind of like paused for about 11 seconds, and I did it on purpose because I wanted to celebrate first very important subject for ASCO this year, which is patient-related outcome. And as we all know, this is really the time for us to interrupt the patient after we tell them about the progression, which is sadly very short time, but that silence of it is really too long. And fascinating that patients really value the input of a PFS. And I have to say that on the other hand, at least from my view, OS is a little bit more difficult to really interpret. As one patient said, like, I was talking about OS and I'm like really kind of altogether. I said, I don't get me. It's like, what's OS?
I think one thing to keep in mind though with PFS, I mean, PFS is a whole debate discussion we can have.
Right.
There's a clear, I think in one of the articles, probably some element of informative censoring in the PFS, right?
Fair.
People that are basically coming off because of toxicity
Sure.
that are going to be censored and will never reach that endpoint.
Yeah.
Right. So all that data is accumulating and you're not going to mature from that perspective. So I think that's an important thing to recognize if there are toxic treatments. The other thing that to me is always very interesting when you have sort of PFS and OS discussions is, I'm fascinated I'm fascinated by the lack of more detailed discussion on the post-progression stuff. I mean, these patients are getting all sorts of different treatments, and if you really dig in and do the math, I mean, it's really, I'm really amazed that there aren't like really detailed analyses of everything they are getting, because we just assume it's the same and we assume it's right, but I assure you it's not the same. So we should really look at that in more detail.
Yeah. So as we saw in the study, and to be fair, we put it in one component and one element under OS. The number of patients who received second-line therapy was about 40%. And in addition to that, if you dissect that further, it appears to be that specifically in the TACE only, in RMC, 40% plus received IO therapy.
Right.
And so this is kind of like really add on a little bit of component. And as we all know, OS is more of a relay race. I mean, you have like different runners being the TACE, you have for the therapy, the IO, etc., and they're all running the same race. And whoever runs further will actually contribute to that lengthening of the OS. And the question for the question about the issue of TACE IO versus TACE then IO thoughts.
I think that's actually the $1 question, right?
Yeah.
I feel like we all have patients like they got TACE, locoregional therapy, and then when they progress, their performance status, liver functions just deteriorate to the point that they just cannot do systemic therapy. So that's the stuff for OS to recommend there.
Yeah.
But I also agree that when we're talking about generalizing to from the trial patient to our actually patient coming through the door and seeing us in the clinic, number one is for sure the medium liver function in my clinic patients is not as good as the trial patient, right?
Yeah.
So when we talk about when we're trying to combine locoregional therapy plus systemic therapy, if they have a very borderline liver function, we probably need to be extremely careful.
Yeah.
And I would say probably not throwing everything on them, including like locoregional therapy plus STRIDE plus Lenvatinib. I think that would be too much for it, already not great liver function. Number two is I also have colleagues who's like, even their very early stage liver cancer will say, hey, how about adding immunotherapy for this patient just because they feel so encouraged by seeing the great results of immunotherapy. I will actually also be very, very careful and say it's really not curable patients that we should be even talking about systemic treatment.
Do you agree?
Yeah, I mean, I think to go back to your point about PROs and what are we doing here in this intermediate stage patient population is challenging. And I'll borrow a line from Katie Kelly that she used at the educational session over the weekend. Are we making, if we're not making patients live longer, or we're not definitively sure that we're able to achieve that yet, are we making patients live better?
Yeah.
And are the therapies that we're giving improving cancer-related symptoms in a symptomatic patient? Are the toxicities that we're giving making patients have more time toxicity coming in for therapy, feeling like they're actively living with cancer under treatment, or can they have breaks that they're seeing Riad periodically every few months for check-ins. I think that still is an open question that we haven't yet addressed here.
No, by all means. And the question is, however, what shall we do? So, Mehmet, it seems that 40% in the TACE received IO afterwards, and about 15% or so received the TKIs in all arms. Patient progress, and to be fair, this is not curative, as we agreed. This is definitely enhancing PFS and OS, but it's not curative. Patient progress, what do you think we're going to give patient next?
Beyond STRIDE plus TACE?
Exactly.
Well, clinical trials would be encouraged, obviously,
Of course,
if this is a advanced HCC at that stage or metastatic disease. I think the available regimens, if we didn't use a TKI, I think that would be a viable option at progression. And also maybe atazobactam might come into place, especially if this disease that we treated was well tolerated.
It seems that Dr. Vogel influenced you quite a bit today with 251.
Maybe, but I think going back to VEGF inhibition with some IO at that stage would be helpful. Or I would also look at the trajectory of the patient, how long they stayed on STRIDE, when we discontinued, why we discontinued, and we know that if this was an IO-sensitive disease from get-go, down the line, you could also revisit that and go back and potentially do another dual immune checkpoint inhibitor therapy. So it really depends on what the patient has done on this regimen. But if they progress while on this, then I would personally favor a TKI-based approach at that immediate aftermath.
Okay, fair enough. I hear that. And Pierre, so as a hepatologist, how do you think the liver works in regard to the checkpoint inhibitors? In other words, if you throw in at progression a reminder of the immune system, i.e. another dose of Durvalumab or change to another checkpoint inhibitors, your thoughts on that?
Yeah, I think generically speaking, immune checkpoint inhibitors are very well tolerated in the setting of certainly early liver disease. I might also add that our ability to determine so-called liver function remains limited. All the tools we have at our disposal are imperfect, whether it's the ALB grade, whether it's the MELD, whether it's just good old bilirubin. None of these are really good reflections to give you a holistic view of where the liver stands. But clearly, over the course of treatment, liver function declines, if anything, because passage of time also typically leads patients to have more symptoms and progression of liver disease. And I think that when you basically open with such a very intensive therapeutic regimen, let's say for the sake of argument, you give somebody Durva, Tremi, and Lenvima, and you also throw in some TACE, what are you doing next, right? You have some difficult decisions to make. Are you giving another second-line approved treatment like cabozantinib? Are you going down the road with ramucirumab? Are you picking another IO doublet? It becomes very challenging to make a rational decision about what the next treatment is. And in my opinion, no matter what that treatment is, you are going to suffer some additional decline in liver function. So you need to be very vigilant at that point in terms of making sure you're not shortening the patient's life by just making their liver disease.
I hear you. So for all colleagues who are listening to us, as you notice, we have a little bit of a challenge debate in regard to really what's OS, what's the PFS. And no doubt that we all are agreeing that the value of adding the checkpoint inhibitors to the TACE showed value, where I just spoke about it. Number two is in regard to what's going to happen next. As we said of the study, the 40% of continued therapy was of different kinds. Intriguingly, the population of the TACE that got the checkpoint inhibitors as second therapy afterwards really bring a little bit of an important point in regard to maybe after all the checkpoint inhibitors should be from the start rather than later on. Because if it was an add-on, we could have seen the same effect ultimately with the OS or what have we. And the question is that Dr. Gholam is bringing up is very valuable is, would you really keep something in the bank for later on, or will you throw in everything? I think the view in oncology is still to really do everything you can for the patients rather than just wait till later on. Because if potentially there's a control of the disease, and to be fair, even we have, despite the small amount, we had some complete response in that study. I think we just have to do what's right in regard to control the patient to the best possible. One more thing we did not talk about yet is adverse events. And to remind all of my colleagues here, the adverse events actually were not anything surprising in regard to the study. They were exactly what we have seen in the standard care therapy being on the TACE, or in regard to the STRIDE regimen of Tremelimab single dose plus Durvalumab on monthly basis, or in regard to the Lenvatinib. Before I kind of like try to reflect a little more details, I would love to really hear some thoughts about like the adverse events like in general. How you read?
Yeah. It's always nice that we're not seeing any additive toxicity. I mean, these are interventions and agents that have been around for some time, so we're not expecting new safety signals. So the fact that nothing is emerging from the combination of the three interventions is certainly reassuring. I think this does loop back a bit to our prior conversation, though, with the lack of efficacy benefit from adding on Lenvatinib. We're clearly bringing some extra toxicity for what cause. So that was a surprising result to me. Certainly, I was hoping to see more of an efficacy signals with the addition of the VEGF-targeted TKI. But if we're not seeing that, we probably shouldn't be giving it.
Right, it's hard to really add Lenvatinib. The other thing is going back to that long-term liver function preservation. We know that from the Himalaya long-term follow-up, they really showed that after at 3 years, the patients who were on the STRIDE arm were able to preserve their liver function, where a patient on the Sorafenib arm clearly liver function deteriorated over time. Of course, this is not just STRIDE. They added TACE, they added TACE and Lenvatinib. So I'm like extremely curious and looking forward to see the long-term follow-up results to see how patients' liver function preserve on all three arms.
Sure. And Dr. Gentry, so in regard to the adverse events, and I'll pick on each one of them, but we'll start with the checkpoint, specifically with the Tremelimab and Durvalumab. I'm sure our colleagues would love to hear your hands-on experience, independent of that study. What will you be worried about? What you will warn patients of? What you will be concerned about? Anything?
Yeah, I think from my experience, when the Himalaya data came out, I felt very gung-ho. Like, oh, this is great. Even like the B7s can tolerate this. And then I think more in my practice, I've been seeing more like mid to late immune side effects just pop up unexpectedly. I would say a lot of endocrine issues. The diarrhea, I don't feel has a bigger uptick, but it's hepatitis. I think has been a major observation of mine as well. So I mean, it's a slow efficacy process, but it sort of also has a sort of a slower AE process as well. That's what I've observed.
No, I probably will all agree with you that it's relatively tolerable. But Dr. Akce, Mehmet, Lenvatinib, your experience?
The hypertension, fatigue, and weight loss.
Which, by the way, we saw a good number of grade 3 hypertension in the study.
It was up there. I think, and that's what we see in clinical practice too. Hypertension is a common problem, which we could potentially address with antihypertensive therapy. But one of the challenges that I find in clinical practice is weight loss and significant fatigue and appetite loss. And that usually derives my decisions to work on getting dose reductions. And some patients struggle with that. And that this weight loss and appetite loss really impacts the quality of life of the patient as well.
Right, that's how I feel. I wonder if actually a lot of my patients taking Lenvatinib, like hypertension is not their complaint, right? Their complaint is I don't feel well, I cannot get out of bed, and I don't want to eat, and I'm losing weight.
Dr. Goyal, to kind of continue on that argument, one of the thoughts that I heard from my co-author, our first co-authors together was Dr. Kudo. He said that we in Japan, we have a rather good experience in regard to the Lenvatinib, and to be fair, they do. And interestingly, we're a little bit, sometimes like more is better, but he was more in kind of like this kind of measured approach. We're very amenable to just drop the dose when we have to and very quickly. Your thoughts on that?
Yeah, as we keep people on these drugs, it's really important that we really monitor their quality of life and check in with them about these side effects. So I do think dose reductions are the way to help with quality of life. Real-time PK would be really an interesting way to see how these levels of drugs are in people's bodies, or real-time pharmacogenomics, I think would be a great way to, over time, be able to figure out how people are metabolizing these drugs, or why certain people's cells are more sensitive to these drugs and they get more hypertension. But yeah, also in my clinic, we start with 12 milligrams generally of Lenvatinib for anyone with a weight of over 60 kgs, start with 8 milligrams for anyone with a weight under 60 kgs, and then we do move to dose reductions. Some people can tolerate full dose Lenvatinib for a period of time, but the vast majority of patients end up having significant dose reductions.
Yeah, and actually, as you saw in the study, we had like a drop off of close to 70% for the Lenvatinib dose.
And Ghassan, don't forget the vascular side effects of the VEGF effect of TKI, right? And so I think there was a 1, 2, or 3 day interruption of the LEN in the LEN arm, strategically around the embolization
part. Exactly.
I'm supportive of that because I'll be honest with you, if I look at sort of my technical adverse events historically, they are on those patients that have on VEGF, on these sorts of things, and they'll cause dissections and spasm, and you can't do what you need to do. So there is a real sort of interventional adverse event profile for people that are on these therapies as well.
I'm glad you bring it up, and actually I was planning to ask you about now the third part of the study, which is the TACE itself. The profile that we showed on the study, your experience, adverse events, any thoughts?
No, I mean, I think this is exactly what is being reported is exactly what we've seen. There's nothing, the one of the arms had a PFS of about 9-10 months, I think a little bit higher than we've seen historically, but techniques are getting better. And, you should see a good 30-40% of bread and butter adverse events that are in the post-embolization family of adverse events. And so I didn't see anything there that sort of led me to be concerned about anything that the TACE was doing worse.
Teach us, we're oncologists. What's post-embolization syndrome?
Oh, well, it's post-embolization syndrome is really defined as...
I like to say it looks fancy.
Yeah, it's fancy. It's not that fancy. It's the idea that you're inducing a very acute and abrupt cytotoxic event.
Okay.
You get tumors that lyse, you get fevers, you get pain. You can get thromboses of vessels, you can get abscesses, you can get gout from tumor lysis syndrome. All of these things have to be managed acutely, which is why most patients that receive TACE are hospitalized for a day or two to manage the pain, to manage those side effects, to minimize that. So that's part of the normal procedure. It's part of the expected adverse event profile.
What's your average for a patient to stay in the hospital after embolization?
For chemoembolization is 1 night.
1 night.
Okay. It used to be longer, but now we prep people ahead of time, maybe. And so it used to be longer, but right now it's about 1 night.
And Pierre, as a hepatologist, any concern in regard to the post-embolization syndrome and recommendation for our colleagues to think of or be worried or not worried about? Your thoughts?
Yeah, I mean, I very strongly echo what Riad said. The interventional radiologists have now a very extensive experience with doing these procedures better and safer, and so you don't really see the side effects or the major complications that you used to see even 10 years ago or 15 years ago. It's pretty rare for someone to have inadvertent vascular injury that leads to significant ischemia. It's honestly pretty rare to see big abscessing disease after. And I don't know what, maybe Riad can educate us about what has changed that you don't really see significant abscess cavities or anything like that after the procedure. It probably has to do with skill and targeting, right? Precision targeting. Right?
I'd like to think it's skill and experience, but it's really a few principles that we've adopted. One is historically, if you recall in the early papers, you would embolize until you reach stasis.
Yeah.
So there's no more arterial flow, which the tumors are highly dependent on. There's the portal vein that takes over.
Yeah.
But now we have this sort of substasis where there's still some flow. We want to deliver agent, deliver therapy, but still maintain flow. So that made a huge difference. And then of course the use of cone beam CT that allows us to see the entire lesion. We cover everything, and so all of these things are sort of technical advancements that are fully socialized, that are part of normal training programs that really have contributed to the even lowered adverse event that Pierre is alluding to.
Sure. And I'm sorry, you had the question.
Yeah, I have a question that is just like sitting on my mind. To Riad. Like for the first dose of TACE on the arm A, I don't think that's a problem at all. But then they started Lenvatinib. For the serial TACE that they received, they only hold Lenvatinib for 2 days before and 2 days after. We know that Lenvatinib is anti-VEGFR. Off protocol, when we give bevacizumab, we know that even after we hold it for a very long time, over a month, people get whatever embolization, the blood sometimes is not flowing into the tumor, and they were not able to embolize the HCC at all. So I wonder on that, would they actually, taking Lenvatinib will have some impact on the serial, the subsequent TACE?
Yes, and I wish I could predict it, but I have seen patients on Len with a nice vascular lesion that is almost completely avascular, even though he discontinued it 2, 3, 4, 5 days before. I can't predict that. I've also seen sort of diffuse arterial spasm of the entire vasculature. Again, I can't explain those mechanisms, but I've seen it, which is why in general we try to compartmentalize and separate those two things. Here, they did them sort of together, but I tend to try to separate them as best I can, because there are times when, and one case happened a few weeks ago where vessel was really vascular, and then on treatment day, I couldn't, and the patient got their they said, could they take their Len? I'm like, yeah, they can take their Len. And I'm like, maybe they shouldn't have taken their Len. So you learn from all of these cases.
One thing
go ahead.
One thing from the med-onc side is because Lenvatinib is a tyrosine kinase inhibitor, the half-life of it is relatively short.
Right, compared
to bevacizumab is a monoclonal antibody. So it hangs on for a couple of weeks. So that might be influencing the time that it stopped before we do.
To be fair, it's not the most robust antiangiogenic. Totally agree with that.
Can I share one more thing?
Yeah, please.
One thing that's really encouraging I felt about this study was the lack of significant hepatitis.
Yeah.
Because I agree with you, Gentry. Sometimes when we give Durvalumab, we do see some hepatitis, although also happy that it's still on the low side. But in this study, among the most common adverse events, even though we were giving triple systemic therapy and TACE, ALT or AST increase or bilirubin, none of those were in the most common. And then for the grade 3, it was around 4% for giving Durvalumab plus TACE. So I found that to be like the absence of that. Sometimes we focus on what's present, but the absence of that was actually quite encouraging to me.
No, I totally agree. And actually, for our colleagues who are listening, and as you noticed, we're all kind of delighted, and we are happy that all the adverse events that we have seen are exactly the one that we would have expected from our already current experience in regard to chemoembolization, in regard to the checkpoint inhibitors, in regard to the DKI being Lenvatinib. What we also heard is that in regard to the checkpoint inhibitors, no concerns at all. Yes, maybe prolonged exposure might really bring in more adverse events. Always important, please remember that anything that patients don't like, let them call you, because we learn with them as we go in regard to how you unleash the immune system against the tumor at the own body. In regard to Lenvatinib, I totally agree. We're a little bit nerved up, all of us, about it. I totally agree. And I second Dr. Goyal, it's a very effective drug, but no doubt, and I do second what Dr. said, is that really the lost weight and the decreased appetite are really a concern. Impressively, that the most prominent was the hypertension in the clinical trial. Regardless, as we already heard, the OS and PFS did not necessarily see more contribution of the Lenvatinib, short of that small population for Japan. And as such, really, we don't really worry much about the Lenvatinib going forward. And lastly, we heard about the chemoembolization and the post-embolization syndrome, which really can be a little bit of an unleashed event. But of course, experience does play, and that's why we see more of those adverse events to begin with. So we're all comfortable with that setting. We still have 3 questions to really discuss and cover on. And the first one to Dr. Salem, it was asked already in the discussion today. What about TARE? Are we going to do this with TARE?
I don't know much about that topic.
By the way, a reminder for our colleague, we're really talking to the guru of the radioembolization over here, and we're honored to have him with us. So, Dr. Salem.
Honored to be here. Thank you. Yeah, I mean, I think, most of my early experience in training was with chemoembolization as the global gold standard.
Yeah.
And, we then observed a new therapy that was more radiation-based than chemotherapy-based, that didn't occlude the vessels and cause the same effect of post-embolization that we're talking about with chemoembolization, with very high doses and prescriptive dosimetry, and really very good outcomes and sort of a broadening on the areas and the categories of BCLC that can be treated with this. So I think, at least in the US, TARE has gained a sort of a prominent foothold on treatment of embolization eligible HCCs. It's doing very well in the bridging patient population as well, and there's a couple other places where it's being investigated. I'm honored to be the global co-PI on EMERALD-3. So we are studying that because I think we need to study Durva-based combination therapies, and that's what we're doing. But I think it's clearly a treatment that is being widely adopted globally, maybe not as much as a TACE, obviously, given resources, but clearly a very high dose, prescriptive, precise radiation-based therapy is playing a big role in the US.
And does it really contribute differently about to that enhancement of the checkpoint inhibitors, or it's the same?
Well, theoretical, as sort of Gentry was alluding to, theoretical. There's some papers from Italy and from Singapore that talk about the rationale of TARE versus TACE in that patient population. I'm going to hold comment because I want to report the EMERALD-3 data as soon as I can. And I think you'll be interested in what we talk about.
It's coming to a theater next to you?
Coming to a theater next year, hopefully. Yes, sir.
Yeah, good.
Yes, sir.
No, that's great. So we really heard from everybody. Mehmet, your colleagues that UAB is going to ask you, hey, by the way, I want to do this with TARE. What do you think? What's your recommendation to them?
So I would wait to generalize for the results of the trial. Anecdotally, it is being done. Because there are patients who don't really quite fit to the trial criteria, but they are also not as advanced unresectable HCC, and you worry that those are patients who already got coupled TACE or loop-directed therapy, and they are just popping disease multiple spots, and those are the patients in our clinical practice, in consultation with our multidisciplinary tumor board, we would interpret liver-directed therapy in the form of TARE and still keep the regimen like STRIDE going. So we've done it outside of a clinical trial, but your clinical trial would be certainly extremely influential to make it a standard, hopefully.
I do think we need to be very careful with over-extrapolation of data. It's the one thing
in
oncology that's a core tenet of what we're taught not to do, right? So this trial is exciting, and it's filling a data gap of what are the outcomes for people treated with TACE plus IO plus TKI. I'm excited to see Riad's data and others on what happens when we use TARE, but they're entirely different mechanisms of action and priming the immune system, so we'll probably see different effects.
I totally agree. Actually, if anything, as you know, at Memorial Sloan Kettering, we use even bland embolization, and we actually had a study NCS sponsored that showed that bland and chemoembolization, there is no difference. But interestingly, when it comes to checkpoint inhibitors, we insisted that we're going to do chemoembolization. Because exactly for the point you're bringing up, with bland embolization, all what you spoke about in regard to the antigen enhancement and the immune checkpoints really being there, doesn't happen. You need the chemo. You have to dirty it up. That's really what it does. So I totally agree with you. In other words, TARE, we urge everybody, and you're hearing from the experts over here, if you have a patient and you have a study available for you in regard to having the radioembolization, by all means, but to try to start exploiting that data just right and left, we have to be kind of like a little bit careful not to make sure that we don't do something that, God forbid, hurt people. At the same time, it might even contribute to the same outcome until we see the data from Dr. Salem and others. So that's great. The other question that really I have, Dr. Goyal, you are a world expert on this, and I was asked this. What about correlatives? What do you think? What do you like to see coming up from that study as correlatives?
Yeah, it's a good question. This is the holy grail in HCC. Such a large population of patients that have HCC, now multiple different treatments for advanced HCC. How are we going to predict what regimen people should go on? I think there's a series of different translational papers that have now come out around the Atezo-Bev data, around the Durvalumab data, but I still think that we don't yet have one that's ready for prime time in clinical care.
Yeah.
So people are looking at different subsets of immune cells and looking at different VEGF pathway biomarkers. But I think time will still tell. We don't have.
Fair enough. Yeah, no, we don't have understanding. And Dr. Gholam, probably tell us from your view as hepatologist, what do you like to see? What kind of data would be intriguing to add as correlatives?
Well, I think one of the ultimate goals of intensifying therapy in the first line, right? However you choose to do it, is to see if you can augment the number of patients who actually benefit from curative therapies, perhaps. And this may be an opportune time to try to do that. As you all know, we have never transplanted more patients ever in the history of the U.S. Year to year. Our transplant numbers are increasing by a whopping 11%. Some people predict that we may actually at one point have a glut of patients, a glut of organs for patients, which would have been completely delusional 10 years ago. So there may be potential for more patients receiving transplants in contexts where the risk of recurrence or return of cancer is high, and that's the only way you learn how to do it, right? You have to take some risks in order to understand who these patients are.
Yeah, no, by all means. One more point is in regard to, and to give credit, the study really was worldwide. And you probably remember I kind of like quoted on that in the conclusion that delighted that Africa was also included in the study. And as you know, we had a study that we did where we looked at the access to care in Africa. And at that time, the access to checkpoint inhibitors was only about 7%. But interestingly, the chemoembolization was very heavily available. And my question is, your views, anybody, in regard to how can we really pass on to all our colleagues in whatever kind of, operation, being governmental, being pharmaceutical, etc. How can we enhance that we get more care for those patients? Because clearly they are embolizing already. Anybody?
That's a great question.
Yeah.
And I think there's a lot of factors that play into that because we're sort of like in our own bubble here.
Right.
And every place in the world has a different situation.
Yeah.
I think small steps in the right direction are being made. I'm going to give a shout out to Lewis Roberts at the Mayo Clinic. Lewis has been a pioneer in making ablative therapies available in his native Ghana and in other sub-Saharan African countries. I think Lewis's work is absolutely admirable. We should be supporting it in any way we can. There have been missions from folks at Sinai and other places to go and educate about how to perform simple ablative therapies. You're not going to have the breadth of expertise that most of our programs stateside have, but I think that teaching, educating, I think it is our collective moral and human responsibility to try to make therapies available to people in sub-Saharan Africa who have a very high prevalence of hepatitis B and HCC.
Correct. Yeah. No, by all means. And to give a shout, I totally agree with you. Actually, as you know, Louis and I and Ashraf Omar, we kind of like are the co-investigator for the access to care in Africa. And now we have data on close to about 800 physicians, and we reported the latest of which at Aortic in Tunisia last October. And delightfully, to give the point that was brought in, the access to checkpoint was increased from 7% to 30%. Mainly because the median age for patients with liver cancer in Africa is about 30 years. Wow. And you know what you call those? They are called the workforce of those countries. Mm-hmm. And already we're in discussion unofficially with different governments, in Ghana, Cameroon, Egypt, is that if you really treat those patients, guess what? They go back in the workforce, which means what? They enhance the economy. And that's really the argument we're doing. It's not about poor them, let's help them out, but rather what you have is an asset that we can really make you empower yourself with to get this study, like the one that we just talked about here, being the add-on of the steroid regimen, tremelimumab plus durvalumab plus lenvatinib to chemoembolization, and we saw altogether it was an improvement in progression-free survival, and of course a trend towards improvement in overall survival that hopefully we'll see coming up to full maturity soon. With this said, however, to be fair, it's nice to hear from all our dear colleagues here their kind of final thoughts, like what your take-home message, your elevator pitch from that presentation today. We'll start with each other.
I think it's a great study. I can't wait for everything to really mature out. As Lipika mentioned earlier, early in my career, I was duped into this, giving checkpoint inhibitors after like Y90, for example, and I felt very uncomfortable with that for all the reasons that you mentioned. But I think when this data I've learned a lot, the value of PFS, waiting for the OS as well, from that perspective as a medical oncologist. But I think this is going to be a very important study moving forward.
Fair enough. Thank you for that.
I think it's the right step in the direction that we would like to go and desire. And the design of the study and the practicality of the study, in my opinion, will resonate a lot in the practices across the globe and will make the multidisciplinary discussions so much fun.
Fair enough, yeah. Yeah, thanks.
Yeah, so I think this is probably the most serious effort to explore the potential, the promise of multimodality therapy, of planned multimodality therapy. And I think if that were to come to fruition, there'd be a number of practical and pragmatic issues we'd have to implement to make it happen. But I certainly hope it succeeds and gives patients better quality of life and longer life. Yeah.
That's great.
Yeah, I'm very excited to see these results presented this morning. Thank you. And I'm also looking forward to, of course, longer long-term follow-up results, OS survival benefits, and also if we could see a tail on the PFS, if we could do more analysis to see who are the patients of population that really, really benefit from the combination of one, that would be great. And also looking forward to the EMERALD-190 and the Rowan study so that we can see the TACE plus immunotherapy, how does it work out?
I would like to ask your opinion, but also, are we going to use this tomorrow?
I think we need a little bit more mature data to see if we're going to use it tomorrow. Yeah. But my take home would be it's another win on the board in terms of earlier introduction of immune-based systemic therapy in the locoregional space. I think the use of CTLA-4 blockade is probably the most exciting part, showing that we're actually seeing potential for OS benefit. I'd like to see that data mature. I agree with my colleagues. I'd like to see what happens when we combine with TARE, which is in line with a lot of what our local practice patterns are in the U.S. But certainly another positive study is another win for HCC patients.
Yeah, but I all agree. Even though we disagree, I'll tell you for sure, I'm using it. And already I spoke with our scientific chair, Dr. Joe Rangeri, a colleague of Dr. Salem, who is at Memorial. And you know what? The therapies are available. We saw robust data today. What are we waiting for? Lipika, what do you think?
I agree with a lot of my colleagues around the data, very encouraging, and we look forward to seeing the mature data. I also feel that this study, for a long time, we've had silos in terms of how we treat BCLC stage A, B, and C. Right. And this study is an argument also in favor of more multidisciplinary collaboration. Right. And I feel like it really emphasizes the importance of presenting these patients in multidisciplinary tumor boards to get the input of our fantastic colleagues in interventional radiology and medical oncology and radiation oncology, just to have everyone figure out what is the best plan for these patients. So I think shifting systemic therapy to the left on the BCLC stage and shifting liver-directed therapy to the right, I think we're going to see more of these trials, but I think it's a very well-designed study, and we look forward to the follow-up data.
Thanks for that.
Yeah, just 2 quick points. One on the PFS, which I think we really don't do that much with PFS. PFS is a very, can be a heterogeneous endpoint because what is the PFS? What is the pattern of progression? A new lesion, these therapies now are so well tolerated. I hesitate to put people on different treatments when something can be ablated, embolized, whatever that may be. I think that's the next really iteration because we just declare any PD as a PD and we move on. I think that's something we need to look at. And then the other thing I would say just to conclude is if there's anything I've learned working with my colleagues over 20 years is, KM curves, OSKM curves, have character and have feature, right? Where are they diverging? Is there crossover? Where is it maintained? Is the hazard ratio constant across? Is there a tail? So I've learned to interpret that. And what I would say is, I'm very satisfied with what I've seen so far. I hope ultimately, all of the statistical criteria are maintained. But I would also caution us not being sort of ultimately just paralyzed by the statistical process, right? At the end of the day, it's about likelihood that your hypothesis is wrong. And whether it's 5% or 6% or 7%, is there really that much of a difference? So I'd sort of open that up because to Lipika's point, this is very compelling information.
No, totally agree. Statistics to help, but not to guide.
Yes.
Absolutely. But again, thanks very much for everybody to listening in. Really, it was a great opportunity and a great pleasure to really be with really robust and highly experienced colleagues from all over the country to really celebrate with us the new data that we had on the EMERALD-3 study. Again, chemoembolization, we are adding onto it the STRIDE regimen consisting of Durvalumab, 1 dose, plus Durvalumab on monthly basis. And as we said, we kind of like Lenvatinib, we're kind of, taking a little bit at face value. It might be applicable for one cohort from Japan, but otherwise, tomorrow morning is STRIDE plus TACE, and we'll see how it goes. Thank you very much for listening.
Thank you.
Thank you. Thank you.